My name is Monika GRUDZINSKA PECHHACKER. I am pediatric ophthalmologist and ophthalmic geneticist and currently fellow at the coordination team of ERN-I. Today I'm going to talk about two groups of conditions belonging to inherited retinal disorders: Leber congenital amaurosis and early-onset retinal dystrophies. Firstly, I will give you a brief introduction to inherited retinal degenerations. Afterwards, we will focus on today's topics. We will talk about definitions, clinical characteristics, how do we meet patients affected with these conditions, which tools are necessary for diagnostics. Then I will show you a few phenotypes that are more specific and worth to remember. Leber congenital amaurosis and early-onset retinal dystrophies belong to a large group of conditions called inherited retinal dystrophies. They are a leading cause of legal blindness in children and adults in a working age group. Of all inherited retinal dystrophies, Leber congenital amaurosis and early-onset retinal dystrophies are the most severe. Approximately 30% of inherited retinal dystrophies are a part of syndrome. Some syndromes have milder clinical manifestations, with not all features present at the same time. For this reason, an ophthalmologist may be the first specialist who sees a patient affected with syndromic retinal dystrophies. The early diagnostics of systemic features is important for a condition to be timely managed to avoid life-threatening complications. Examples of syndromic retinal degenerations are metabolic and mitochondrial conditions affecting a variety of organs, and a large group of conditions named ciliopathies, such as Bardet-Biedl syndrome or Leber syndrome, which are discussed in detail in other sections of this module. For decades ago, the way how we talked to the patients was different. As you may see, in the 80s, there were 2 to 3 genes known to be associated with inherited retinal dystrophies. Now there are almost 300 genes, and the knowledge is constantly evolving. There is a sense of hope. Our priorities have shifted to identifying causative genetic variants and to determine which patients might be eligible for trials or treatment. Genetic testing is now a standard of care and has improved to the point that we can now identify causative pathogenic variants in up to 75% of patients. The inherited retinal dystrophies are genetically heterogeneous, meaning that the same set of genes may be associated with retinitis pigmentosa, with Leber congenital amaurosis, macular dystrophies, congenital stationary night blindness, among others. This requires that ophthalmologists taking care of patients affected with these conditions have specific knowledge, which need to be continuously updated. Leber congenital amaurosis is rare among inherited retinal dystrophies and accounts for around 5% of all inherited retinal dystrophies. Recognized and described for the first time in the 19th century by Theodor Carl Gustav Leber, Leber congenital amaurosis was initially introduced as the congenital form of retinitis pigmentosa. Currently, most vision scientists consider Leber congenital amaurosis the most severe retinal dystrophy without major systemic features. According to the literature, it affects 1 in 30,000 individuals to 1 in 80,000, depends on the study. Around 20% of children attending schools for the blind are affected with Leber congenital amaurosis. Leber congenital amaurosis is the most severe retinal dystrophy, causing blindness or severe visual impairment before the age of 1 year. whereas early-onset retinal dystrophy is less severe and has the onset after 1 year and before 5 years of age, according to the definition. However, in the clinical settings, the differentiation between two of them may be challenging due to the difficulty in assessing the time of the first symptoms and similar clinical features. So a child affected with Leber congenital amaurosis presents with severe and early visual loss, absence of fixation, nystagmus, poor pupil responses to light, and non-recordable or flat ERG. Parents have concerns very early that their child may not see. Manifest visual function and visual acuity range widely, usually from 20 to 100 or 0.1 to light perception or even no light perception. Most patients have relatively stable visual function, but some patients progress. We need to bear in mind that assessment of visual function in children is different than that in the adults, and that visual functions are still under development at this young age. Another important aspect is that low vision and nystagmus can be also a sign of life-threatening neurological condition, which cannot be missed in the early workup at this stage. So it is very important to point out that visual impairment in children affects not only vision, but also general child development, such as motor skills and psychosocial development. The evaluation of a child with suspicion of Leber congenital amaurosis or early-onset retinal dystrophy starts with detailed medical history, including pre- and perinatal history. A 3-generation family history should be taken with attention to relatives who have manifestations of Leber congenital amaurosis and consanguinity. Also, it may be useful to examine relatives or review their medical records, including results of genetic testing. Ocular exam in children is difficult and requires different instruments than in adults, such as portable slit lamp and portable biomicroscope. Also, imaging possibilities are limited compared to adults. The exam may be influenced by the child attentiveness on that specific day and sometimes may require more than one visit. Importantly, patients affected with Leber congenital amaurosis often have high refractive errors, from hyperopia to myopia, but most patients are high hyperops. Regarding anterior segment features, they may have keratoconus or cataracts, but they are not always present. The fundus vary considerably and ranges from essentially normal fundus to variety of abnormalities. Assessment of retinal function using full-field electroretinogram is mandatory and can be performed awake using shortened protocol, under sedation or general anesthesia, dependent on the institution. So after the phenotype is assessed, it's time to order a genetic test. Because Leber congenital amaurosis and early-onset retinal dystrophies are genetically heterogeneous and difficult to distinguish from many other inherited retinal dystrophies, recommended genetic testing includes either gene-targeted testing, such as multi-gene panel, or comprehensive genome testing, exome or genome sequencing. The fundus can appear normal, as you may see on the left-hand side of the slide, or show a variety of retinal abnormalities, including pigmentary retinopathy, white deposits at the level of the retinal pigment epithelium, vascular attenuation, or pseudopapille edema and macular atrophy, as you can see on the middle image. Those with a normal fundus at birth usually develop pigmentary retinopathy, optic disc pallor, and vascular attenuation with time. Other later changes include, for example, optic disc drusen, as you can see on the upper right-hand side image. Some genetic subtypes have a characteristic retinal phenotype. It is important to remember that fundus can appear normal even if ERG is non-recordable. Briefly about visual erectroretinography, or ERG. ERGs can be recorded from infants and young children, but interpretation of results must take into account any variations in recording methods, compliance, and age-appropriate reference data. Lower ERG amplitudes and longer peak times generally apply below 6 to 12 months of age under dark adapted conditions and below 2 to 3 months of age under light adapted conditions. So here you can see the recordings from 3 children affected with Leber congenital amaurosis in dark adapted conditions, first 2 traces on the left hand side, and light adapted conditions, 2 traces on the right hand side, compared to healthy control, the lowest panel. It is not hard to see that both scotopic and photopic responses corresponding to rod and cone photoreceptors are significantly reduced in individuals affected with Leber congenital amaurosis. For the pediatric ophthalmologist, the clinical presentation of Leber congenital amaurosis and early-onset retinal dystrophies represent a complex dilemma, as many non-syndromic and syndromic ocular diseases with LCA-like ocular phenotype present in a very similar way, and the clinical overlap can be striking and confusing. The conditions that overlap because of similar early-onset visual loss, nystagmus, and initial retinal appearance are achromatopsia, congenital stationary night blindness, albinism, and optic nerve hypoplasia. These conditions are explained in the details in other parts of the retina module. An LCA-like ocular phenotype can be also found in several syndromic diseases, which may initially present without the systemic features, but may dominate the phenotype later in life. The most important are Batten disease, ciliopathies, paroxysmal diseases, and cobalamin C deficiency. Also, presentation with nystagmus, low vision, and normal fundus may give an initial suspicion of neurologic emergency, even in a baby without any other neurological symptoms. Thereby, MRI exam earlier than ERG may be necessary to exclude, for example, brain tumor. This topic will be covered extensively in the pediatric ophthalmology module. So let's take a look together at these images. On the left-hand side, you can see the fundus with a bullseye maculopathy, retinal vascular attenuation, and optic disc pallor. OCT shows significant macular atrophy with almost complete loss of the ellipsoid zone, hyperreflective dots at the outer retinal level, and atrophy of the outer nuclear layer and also inner retina. ERG often presents as electronegative, and these are the hallmarks of Batten disease. The signs of Batten disease can be diagnosed by the ophthalmologist. Usually we see a young child with bilateral, rapidly progressive vision loss and macular disturbance. Interestingly, neurologic or cognitive symptoms may not be present at the beginning, but early diagnosis is important both to provide timely clinical management and support, and to facilitate the access to novel therapeutic interventions at the early stages. So regarding management of most forms of Leber congenital amaurosis or early onset retinal dystrophy, the management is symptomatic. The only form for which specific therapy is available is RPE65 related disease. In general, children affected with Leber congenital amaurosis benefit from correction of refractive error, use of low vision aids when possible, and optimal access to educational and work-related opportunities. We should bear in mind that vision in young children is still developing. Children and their parents should be referred to programs for visually impaired children within their location. As affected individuals grow older, further assistance, including financial or employment assistance, offered by the country is very important. Then, of course, genetic counseling for affected family allows understanding the condition and its implications, as well as estimating the risk for other family members. Prenatal and pre-implantation genetic testing are possible. Another important aspect is a psychological support for family at the time of diagnosis and follow-up visits. Supportive patients' organizations play also an important role in the life journey. So to date, mutations of 24 genes accounts for 70 to 80% of individuals with Leber congenital amaurosis and early onset retinal dystrophy. And the most common, studied recently in this large German population, were CEP290, CRB1, RPE65, and RDH12. Some differences in frequency may appear dependent on geographical location of studied population. The genetic testing is a standard of care and is performed after assessing the patient's phenotype in detail. Genetic diagnosis allows adequate clinical and genetic counseling, as well as enrollment into clinical trials or treatment. So the first gene replacement therapy, Luxturna, for Leber congenital amaurosis and retinitis pigmentosa associated with B-allelic pathogenic variants in RPE65, was approved in 2017 in United States, in 2018 in Europe, and since then is in use in many countries. Furthermore, over 40 clinical trials have been initiated. Also, following successful gene supplementation therapy in experimental models of AIPL1, RDH12, JUC2D, and RPGR-IP associated Leber congenital amaurosis, clinical trials are likely in the future. Other forms of gene therapy have been also used in trials, for example, JUC2D, or CEP290 associated Leber congenital amaurosis, which has been terminated for now. So now I would like to share with you some LCA phenotypes. On the left-hand side, you can see a fundus of 8-year-old patient with mutations in AIPL1 gene. On the right-hand side, images of patients affected with NMN81 related LCA. What they have in common are prominent macular colobomas. The term coloboma is a misnomer, as they are not developmental colobomas. Colobomas are not found in all genetic types of Leber congenital amaurosis and may be easily confused with the scars of ocular toxoplasma. Here on the left-hand side, you can see fundus images of patients affected with CRB1-related Leber congenital amaurosis. The characteristic changes are nummular pigment changes and preserved para-arterial retinal pigment epithelium. Also, CRB1 patients have often maculopathy with macular edema or schisis. In the middle panel, there is a fundus of young boy with rapidly progressive disease, prominent maculopathy, due to pathogenic variants in RDH12 gene. And on the right-hand side, there is a fundus of a 10-year-old girl with a prominent maculopathy and relatively normal appearing vessels and optic disc due to a heterozygous mutation in CRX. So CRB1, RDH12, and CRX presents often with maculopathy. Here on the left-hand side, you can see a fundus of 40-year-old male patient with homozygous mutation in CEP290. You can appreciate the marked choroidal sclerosis, pale optic disc, barely visible retinal vessels, and relative preservation of the posterior pole. Then, in the middle image, you can see a fundus of 25-year-old female patient with a relatively normal retinal appearance, including retinal color, retinal vessel caliber, and optic disc. She has mutations in JUC2D. And on the right-hand side, the image of a 20-year-old male patient with RPE65-related Leber congenital amaurosis with characteristic retinal pigment epithelium translucency and relatively normal vessel caliber and optic disc. RPE65-associated disease, treatable with proved improvement or at least preservation of visual function, may have variable phenotypes leading to diagnostic difficulties. Fundus can present with bone speckle changes, as shown in the upper left-hand panel, pigment dispersion in the mid-periphery, as you may appreciate in the lower left-hand panel, or white dots scattered in the retinal periphery, as in the right-hand panel. It is worth to remember that there is usually lack of physiological blue light autofluorescence. So approaching to the end of this presentation, I would like to point out that children are not young adults. The clinical exam is different and diagnostic tools are different. The disease phenotype may be different because the condition has another stage of progression. Also, overall management of the disease is different than that in adults because the vision is developing and a child is developing. So to summarize, we have learned today about Leber congenital amaurosis and early onset retinal dystrophy, which overlap with a wide range of conditions in terms of symptoms and clinical features, and they are a diagnostic dilemma. These conditions are gene-specific, but a detailed clinical exam is important before ordering a genetic test. RPE65-related Leber congenital amaurosis is an actionable disease. Patients' and parents' perspective are very important on each level, from diagnostics through follow-up visits and all the way towards therapy. Psychological aspects of patients' care are crucial, as well as early enrollment into low vision institutions. Adequate and updated information about the condition and management, including clinical trials, matter. Regular follow-up visits are also very important. Thank you for your attention.